Well, good morning, everybody. I'm Dave Goldstein, and I'm the chief of the Clinical Neurocardiology Section in intramural NINDS. And I'm giving a case presentation today on a case of Grinch heart. The patient is a 20-year-old Caucasian man who, with chronic orthostatic intolerance and frequent syncope, frequent fainting. He was referred through the NIH Undiagnosed Diseases Program. He had problems from birth. He was hypoglycemic, had a low APGAR score, learning disability, and severe pectus excavatum, for which he had 2 surgeries, and also had multiple pacemaker insertions in an attempt to treat the syncope without benefit. He also complained of fatigue, depression, chest and back pain, and sleepiness. Laboratory findings from the outside that were confirmed here included, quote, endocrinopathy, unquote, with low testosterone, low TSH, and high ACTH. He is a quite tall and thin person, and given the pectus excavatum, Marfan syndrome or Ehlers-Danlos syndrome were considered, but clinically he's not marfanoid. And he was referred for autonomic function testing. Well, one of the teaching points for today is that there isn't any autonomic nervous system. First of all, the autonomic nervous system isn't autonomic. It's not independent of voluntary control. For instance, if I wanted to activate the sympathetic nervous system, all I would have to do would be to go like that. And it's just sort of built in that the sympathetic outflow will go up in response to isometric tension. I think of the autonomic nervous system as the automatic nervous system, but I'm going to be using the conventional term autonomic from here on in. It's very important to recognize that this isn't a single entity. There is no such thing as autonomic function testing, because the autonomic nervous system consists of multiple components. There's the classical parasympathetic nervous system, a phrase that was coined by Langley. There's the enteric nervous system, the sympathetic noradrenergic system, which is responsible for much of cardiovascular regulation. There's a component of the sympathetic nervous system that's cholinergic and is responsible for sweating. And since the days of Walter Cannon, who coined the word homeostasis, as well as the phrase fight or flight, there's been the idea of a unitary sympatho-adrenal system, an emergency system activated during distress. So there are at least 5 components to the autonomic nervous system, and these have different clinical manifestations. There are different clinical correlates. As I mentioned, the sympathetic noradrenergic system is responsible for much of cardiovascular regulation, and so symptoms of sympathetic noradrenergic failure could include orthostatic intolerance, as in this case, an inability to tolerate standing up. My usual screening question for orthostatic intolerance is, who does your shopping? Because what I'm looking for is the answer, well, not me, because I can't tolerate standing up online. Parasympathetic cholinergic system problems are reflected by constipation, urinary retention, decreased salivation, tear production, and so forth. There are also a variety of clinical laboratory tests for assessing these components of the autonomic nervous system. Today, I'm going to be talking about the results from just a few. I'm going to be talking about the Valsalva maneuver, which is probably, from my point of view, the most important test of the sympathetic nervous regulation of the cardiovascular system. We're talking a little bit about skin electrical conductance as a measure of sweating, and therefore a measure of at least partly sympathetic cholinergic function. And I'll be spending a little bit of time on neurochemical measures, in particular levels of the catecholamines norepinephrine and epinephrine, which is synonymous with adrenaline. Now, when a person performs a Valsalva maneuver, or blows against the resistance for several seconds and relaxes, there are 4 classical phases of the blood pressure response. In phase 1, as soon as the person starts to blow against the resistance, there's an increase in pressure in the chest, blood comes down the arms, the blood pressure goes up for a second or two. This is a mechanical phenomenon. It doesn't have anything to do with reflexes. But then, as the person continues to blow against the resistance, there's less blood that comes up to the heart. The heart pumps out less blood, and the brain picks up on that immediately. Hey, where's my blood? This causes a reflex where the sympathetic noradrenergic system is activated. The chemical messenger of the sympathetic nerves, norepinephrine, is released. Norepinephrine binds to receptors on cardiovascular smooth muscle cells. And the blood vessels constrict, and because of that, the blood pressure starts to creep up. Then the person relaxes. In phase 3, the blood pressure goes down momentarily. This is a mechanical thing. It's like a mirror image of what happens in phase 1. It doesn't have anything to do with reflexes. And then finally, in phase 4, the blood pressure creeps up towards baseline. Because now there's no impediment to venous return to the heart pumps a normal amount of blood, but it pumps it into this reflexively constricted vasculature, and so the blood pressure overshoots. Now, in somebody who has a sympathetic neurocirculatory failure, whether it's from a Barrow reflex problem and the brain doesn't know what the blood pressure is, or the brain doesn't care because there's some disease state, or the sympathetic nervous system isn't there, or norepinephrine isn't released, or the receptors are blocked. Regardless, you get the same abnormal pattern of blood pressure. In phase 2, the blood pressure just goes down, down, down. Well, that's because the person can't tighten the vascular nozzle reflexively to bring the pressure back up. And in phase 4, the blood pressure slowly comes up to baseline, but it doesn't overshoot for the same reason. The person was not able to tighten the vascular nozzle and bring up the pressure. And you can see also, typically, heart rate goes up when the blood pressure goes down. That's what the Barrow reflex is about. And so in this patient, you see this flat heart rate, despite a larger decrease in blood pressure, indicates failure of the Barrow reflex the heart rate component of the Barrow reflex, which is dependent mainly on the regulation of parasympathetic cholinergic outflow. Now here's the Valsalva maneuver in our patient. He had an arterial line in, and this is the arterial pressure. He also had a finger cuff for non-invasive measurement of blood pressure, and I think you can see the amazing fidelity of this non-invasive measure. But at any rate, we're going to be looking at the intra-arterial pressure. And there are a couple of very remarkable abnormalities. First of all, this guy's referred for possible autonomic failure as an explanation for orthostatic intolerance. Does this person have failure of sympathetic vasoconstriction? Anyone? Feel like it's Ferris Bueller's Day Off?
No.
No, that's right. Because look, he's able to preserve his pressure in phase 2. He has this humongous overshoot, right? This is very abnormal, excessive overshoot. So there's no way this guy has sympathetic neurocirculatory failure. This is a very large hypertensive response and very prolonged. This is quite unusual. Has to be explained. Perhaps less well appreciated, he didn't have any increase in heart rate. So he did have vagal-reflex cardiovagal failure, even though vagal-reflex sympathoneural function was entirely intact. Yes, down, first of all, you can see his heart rate is about 140. And down here, you can see, that here this is his EKG. These are paced. So something turned on this pacemaker, but his heart rate was 140. And it turned out he had a very interesting pacemaker where it's not just the heart rate that triggers the pacemaker, but also something related to intracardiac impedance. I don't have time to go into what this thing was sensing, and frankly, I don't know what it was sensing. I don't think anybody knows what it was sensing. But this was supposed to be a fancy way to detect a problem with cardiac output, even if the heart rate were okay. And so the pacer would kick in, and hopefully this would prevent syncope, which it didn't. In fact, you can see that when the pacer did kick in, if anything, the blood pressure decreased. It didn't help at all. But that certainly complicated matters, and because of this, we subsequently had a team from the cardiology branch of Heart, Lung, and Blood Institute come, and we repeated this Valsalva thing with the pacemaker off. And basically, this abnormal pattern with this huge overshoot was still there. So the pacemaker complicated things, but the abnormality is there, independent of the pacemaker. So we've got intact sympathetic function, in fact, sympathetic hyperreactivity, I would say, for some reason, and vagal-reflex cardiovagal failure. Now, in the real world, tilt table testing is done very frequently to evaluate people with orthostatic intolerance. And this is designed to show, first of all, he didn't have orthostatic hypotension. However, during prolonged tilting, eventually, I'm going to show a blow-up of this in a minute, eventually his blood pressure did decrease enough that I thought he was going to faint if I pursued this, and I didn't see any reason to. But it took a long time, more than 20 minutes. In people who have orthostatic hypotension, this is a slowly progressive phenomenon and is overt by 3 minutes. So he had delayed orthostatic hypotension. This is his skin electrical, it's called GSR. It's not a galvanic skin response, but it was a measure of skin electrical conductance. And you see, during the tilting, he had this very impressive sweating response. In fact, by the end, he was above our scale. He was just drenching wet. Now remember, that's supposed to be a sympathetic cholinergic phenomenon. So it appeared that he had vagal-reflex cardiovagal failure. That's parasympathetic cholinergic. He had intact sympathetic cholinergic function, so it's not a cholinergic problem. And he had intact sympathetic neurocirculatory function. This is just a blow-up of what happened at the end. And I decided it was time to get our last sample and put him back down. and his blood pressure very rapidly recovered. Now, we measured his forearm vascular resistance non-invasively. I'm not going to go into how we did it, but we did this throughout the tilting. And what you could see is that at first the forearm vascular resistance goes up. This is on a log scale, by the way. Goes up very nicely. Well, that fits with reflexive sympathetic noradrenergic stimulation because the blood vessels in the forearm are constricting. But then, in contrast with what happens normally, where the forearm vascular resistance just sort of stays up, you can see that his forearm vascular resistance decreased progressively during the tilting. It began many minutes before he began to feel bad. He never actually fainted. And this fall in forearm vascular resistance is mirrored by what happened to his skin electrical conductance. Ordinarily, when people are tilted, they do have a little bit of a sweat response, but then that kind of peters away. In his case, he had a progressive increase in sweating during the tilting. So something was causing his forearm vascular resistance to go down, and something was causing him to sweat. The arterial plasma catecholamines were very instructive in this case. Now, normally when a person stands up, the plasma norepinephrine doubles by 5 minutes of standing, and then it stays that way. That means 100% increase. And adrenaline or epinephrine increases to a smaller extent, but it increases by about 2/3. In his case, you can see this drastic increase in both adrenaline and norepinephrine within 4 minutes of the tilting. It was one of the larger increases in adrenaline that I've come across. And then, subsequently, the norepinephrine, the norepinephrine continued upwards, and between here and here, you see there's no further increase in norepinephrine, whereas the adrenaline went up progressively. Remember, this is on a log scale, so there's a very substantial increase in adrenaline, and by the time he felt bad, his adrenaline level was really very, very high. Now here you can see that the skin electrical conductance and the forearm vascular resistance are like mirrors. Similarly, the adrenaline and forearm vascular resistance were like mirrors. And you'll notice that his forearm vascular resistance went below baseline several minutes before he began to feel bad. And this just shows that in this case, both the skin electrical conductance and the forearm vascular resistance were correlated with arterial adrenaline levels. Now, this phenomenon of his mirror is new, not new, and I described this several years ago already. Here's an example. This is a patient who did faint after a long period of tilting. And here's the arterial adrenaline, again on a log scale. Here's the norepinephrine. And you see beginning here, there's sympathoadrenal imbalance. The norepinephrine is kind of stabilized, but the adrenaline is going up progressively. And here's the forearm vascular resistance. It goes up initially, then it goes down. And here is where it crosses baseline. And now there's forearm vasodilation. This is several minutes before the fall in blood pressure, which is shown here. And I think was the cause of the fainting in this patient. And we studied many people, we used to study many people with chronic orthostatic intolerance. And in people who faint, prior to the fainting, there's this phenomenon of sympatho-adrenal imbalance. All right, so that's why he has orthostatic intolerance and fainting. It's because this sympatho-adrenal imbalance. So why is he a fainter? As I said, we had a team from the cardiology branch come to evaluate him formally, and he was found to have a low stroke index. That is to say, adjusted for his body mass index, the amount of blood that his heart was ejecting per beat was too low. Stroke volume is too low. Well, then it all kind of makes sense. When the person who already has got a low stroke index is tilted, and there's a further decrease in stroke volume, then the sympathetic nervous system is recruited in an attempt to maintain cardiovascular function. So the activation of the sympathetic nervous system is compensatory. Why is this Grinch heart? Some of you know the story, but here is text from it. And once you get down to the last sentence, you can understand why this is a case of Grinch heart. It's a really cool name for a syndrome. I don't take credit for it. This was published by a colleague, Ben Levine, a few years ago, where he uses the word somewhere in there. I can't read it that well. Here we are, down here. So in conclusion, this is a patient who had sympathetic hyperreactivity and postural tachycardia, which I thought was a compensation for chronically decreased stroke index. And the reason for the decreased stroke index was obvious, his severe pectus excavatum, which of course was congenital and which I think interfered with normal growth of his heart. He had neurally mediated hypotension, and his fainting was probably from sympatho-adrenal imbalance. One thing that all this doesn't explain is why his adrenaline level went up so much with just 4 minutes of tilting. And I think this is because of classically conditioned adrenomedullary activation. Every time for many, many years, basically for his whole life, that he's tried to get up, within a short period of time he feels terrible. And this is a classical conditioned distress response. So what did I recommend? Well, I recommended, first of all, there's no reason to have a pacer. It clearly does not help. In fact, as I showed, when the pacemaker was turned on, the blood pressure actually fell. I think tailored exercise training is of value in general in postural tachycardia syndrome and is worth a try. To try to build up the stroke volume, it's not easy, but the standard approach would be a salt-retaining steroid, fludrocortisone, and a high-salt diet. I would consider alprazolam because of its power in inhibiting adrenomedullary secretion during distressing situations. And probably most importantly, I'd reassure the patient that although he's got a very debilitating condition that probably is never going to go away, it's not going to progress to a true neurodegenerative disease and autonomic failure. And finally, I want to thank the clinical team who helped with the evaluation of this case, and Doug Rosing of the cardiology branch in Heart, Lung, and Blood Institute. And thanks for your attention.